right, thank you so much for being here. We're going to go ahead and get the meeting started now. Let's have a few quick disclaimers to share first. So I want to let everyone know that this meeting is being recorded and live streamed today on TVW. The meeting will also be shared on the State v. Blake webpage, ESB 5476 webpage. This recording is open to public disclosure, so please do not disclose any private or confidential information. And when it comes to the guidelines for public feedback, there will be 20 minutes designated for public feedback near the beginning of the meeting today. Each person will have 3 minutes to provide feedback. Non-committee members will remain muted until it is time for them to share feedback if they would like. Feedback that's not provided during the meeting can always be submitted via email to HCA ESB 5476@hca.wa.gov. And with that, I will go ahead and move into the roll call. We'll see who's here this morning. We'll start with Michael Langer.
Present.
Good morning. Amber Leaders.
Good morning. Present.
Good morning. Senator Dingra. Senator Braun. Representative Davis. Representative Griffey. Caleb Bantagreen.
Good morning.
Good morning. Don Julian Saucier.
Good morning.
Good morning. Kiara Fisher. Alexi Orr.
Here.
Morning. Amber Daniel.
Yep, I'm here.
Thanks, Amber. Brandy Flood. Stormy Howell. Chad Enright. John Hayden. Sarah Milfy Klein.
Good morning.
Good morning, thank you. Sherry Candelario.
Good morning.
Good morning. Hallie Birchinall. Teresa Adkisson.
Good morning.
Morning. Sarah Gillard.
Good morning.
Morning, Sarah. Donnell Tanksley.
Good morning, team.
Good morning. Malika Lamont.
Present.
Good morning. Addie Atwell.
Present.
Thanks, Addie. Kevin Ballard.
Good morning.
Good morning. Hunter McKim. Kendall Simmons. Representative Taylor.
Good morning.
Good morning. And Representative Mossbrucker. All right, thanks everyone. And
Michelle?
instead of, oh, sorry, go ahead, Michael.
Michelle?
Yeah.
I'm sorry. It looks like a few have joined since you started going through the list. So
Oh.
if you did not have a chance to let Michelle know you're here and you're a member, would you please recognize yourself so she can get it for the notes?
Michelle, this is Manka. I'm here.
Good morning. Thank you.
Good morning.
All right, thanks
Okay,
everyone. Yeah. So rather than having someone read norms and expectations to save a bit of time this morning, those have been attached to the meeting for your reference if you'd like to review them. But we're going to go ahead and move right into the public comment, unless, Michael, you had anything you wanted to say before moving on to the second agenda item.
Yeah, what I really want to say is the Mariners are going to the playoffs. So I thought I'd start with a positive here today. I had a chance last Friday to go up and participate in the counselors. It was both WADAC and NADAC, the Substance Abuse Counselor Conference on Workforce, which was very enlightening. Good listening session on Friday. But then I had that chance to go and watch the game. And I'm not sure. I think the whole Northwest is still celebrating after the big victory. So it's nice to get some community spirit going. I also want to certainly thank you all for being here again today. And thank you for last week. For those of you who were able to participate, it was a long, we had scheduled 5 hours. We did not take all that time. But I think to the preparation of the subcommittee proposals and those that were presenting them, we got through those in pretty good order. So thank you for hanging in there, putting in extra time on top of extra time to get us to the end here today. So with that, I wish us luck today. I know the proposals are just as worthy to be considered, and we will see how long it takes us to get through. But thank you for giving more of your time today to make this important work happen. So with that, I would transition it over or back to Michelle, and we'll start the public comment, I believe. So thank you, guys.
I'll go ahead and take that, Michelle. So Blake Ellison with the Healthcare Authority. Good morning. We are going to take 20 minutes for public comments, 3 minutes per comment. So we'll open that up now. If you'd like to just go ahead and raise your hand, that would be great. Again, this is time for public comment. If you have anything that you want the committee to know or think about, or just want to express ideas, please do. Again, calling for public comment. We'll give it another minute. Again, calling for public comment. Any public comment? All right, Michelle, should we turn it back over to you? Okay, thank you.
All right, so next on the agenda, we're going to move into the discussions and final votes for the recommendations that were sent out last Thursday morning to the SURSAC. We're starting with recommendation number 9, the Washington Recovery Helpline and Asset Mapping Tool from the Recovery Support Services Subcommittee. And let's see, I believe that Alan Muya is going to provide the overview. I'm not sure if he's on quite yet because we are ahead of time. So you all have copies of the recommendation, and I would like to just open up for any comments, questions, discussion from what you've read as we're waiting for Alan to come on and provide more of an overview. At least I don't think he's. Alan, are you on yet? Okay. Yeah. So are there any questions
Michelle,
or comments?
do you want to go to
Yeah.
I was wondering if we're waiting for the presenter for the first one. Do we have the presenter for the second one? Would we like to go to that and come back to the first one?
Yeah, that might make more sense. So the next one is recommendation number 12. This overview would be from Amber Daniel and Tim Candela from the Outreach, Engagement, and Diversion Subcommittee on Stigma Reducing Outreach in Schools. Amber and Tim, are you ready to do an overview on this one?
Sure. Is that what we're doing right now? Let's do it. Is Tim here? Woo. All right. Did you want to just give an overview and then I can just add to it? Does that work?
Yeah, that works.
Okay.
Michelle, do you have this handy really quick just to do a quick screen share? It helps me do the overview, and I know folks have reviewed it, but it helps me out a little bit too. Thank you. Well, thank you so much. So this recommendation is really focused on naloxone administration and overdose identification within Washington State Public Schools, primarily between the grades of 6 through 12, and the efforts to reduce stigma and save lives. The intended audience for this recommendation does include students, administrators, teachers, and other educational professionals. If you scroll a little further down, we provided our background and supporting data talking about the mortality rate related to young people who are experiencing overdose. And then within that, we're also making a recommendation that there needs to be proper drug education to young people within school settings, in addition to having access to naloxone. We did provide a hyperlink for one curriculum that's evidence-based and is currently being utilized within San Francisco Public Schools, which is the Safety First curriculum put out by Drug Policy Alliance. If you go a little further down, as mentioned in the last meeting, I think it was Michael Langer who asked the question around young people in possession of a hypodermic syringe. There is the RCW as well, highlighting that individuals under the age of 18, there are some things that prohibit them from receiving that, which could impact their ability to receive intramuscular naloxone, since within intramuscular naloxone kits comes a syringe. So if you go a little further down, this is more just of our background. This recommendation is also seeking, so one of the crux of this is the education curriculum within the school setting. And then also the funding would be utilized to do outreach and communication strategies for young people. And then also it would allow naloxone to be stocked at schools in the event of an overdose, and allow school health staff to provide naloxone to students upon request in a confidential manner. Below are some of our concerns and considerations. They are quite robust. We had representation, provide feedback from OSPI, and then also a local school district. As you can see there are a few considerations, especially when we're talking about the curriculum. You know, the feedback that we got is the school year is already packed, and if we are adding to the curriculum, we may need to potentially add a day to school. So looking at mitigation strategies around that, again, there would need to be intensive stakeholdering opportunities with parents and custodians of young people. Go a little further down, please. Those are collaboration with existing resources. We have the cost. There are approximately 500,000 students in Washington State between grades 6 through 12. So we did 10% of that 500,000, which came out to 50,000. And then we also added some other funds dedicated to FTE to actually administer this program, and then also funds for the outreach and communication and curriculum build back. So this is one of our attempts at reducing stigma, especially amongst a population that is disproportionately impacted by overdose. So Amber, you want to go ahead and help fill in the multiple gaps that I may have left?
Yeah, sure. I think that the idea for this recommendation came out of the fact that I live in a rural community where there's a really disproportionate amount of gang violence for how many kids we have, and these kids are doing these drugs and they are overdosing, and it's really scary. I think that if kids are allowed to get a CPR card and be babysitting younger children, they're old enough to spot signs of an overdose and old enough to be able to reverse it if they're trained how to do it. And I think a lot of kids, from my experience of working with kids in the JJC here, they feel really helpless. Like, what can I do? My friends are doing this stuff and I don't know how to help. Or maybe my friends' parents or older siblings. And we are in the middle of a severe crisis. This needs to happen. Kids need to have access to naloxone. They are able to help if something goes down. And I really have a big heart for this recommendation. I think that it could really change the numbers that are really scary. That's all.
All right, any questions, comments, concerns? Just go ahead and raise your hand. Caleb?
Good morning.
Morning.
Having worked in this area around naloxone for a long time and spoken with a lot of schools and done a lot of overdose training, I'm surprised a few things seem to me to be missing, which is an overt mention of the Good Samaritan law, which I think is one of the biggest pieces of low-hanging fruit to talk about with youth. Surprised fentanyl isn't mentioned explicitly, and I'm also don't understand how this addresses stigma. I see how it addresses overdose response, but there's nothing in there about content around stigma. Specifically, for me, stigma reduction would be speaking something to the reasons that people use substances, that those are rational in the context of their lives, and from a prevention standpoint, that family and friends and schools need to look out for people exhibiting those signs. That would help with stigma, that it isn't just bad people doing bad things at all, but in fact it's normal people doing typical things and understanding why that's happening. I know, and so I'm sort of surprised that's not in there, and I'm hoping maybe somebody could speak to that.
I'll speak to that. So that attempt is within the Safety First curriculum. So that is providing harm reduction based drug education to young people in a non-stigmatizing way. So it talks about, for folks who aren't aware of the Safety First curriculum, I strongly encourage you to take a look at it. Like I said, it's starting to be implemented, and that is the direct attempt, is having realistic conversations around drug use with young people. So it's the complete inverse of what DARE was. So that is our attempt at addressing stigma, is talking about drug use in a realistic way with young people starting in the 6th grade all the way up to the 12th grade. Good point. Yes, the disparate overdose for young people is disproportionately driven by fentanyl. That is something that we can add, but we also are aware, and it's touched on with the Safety First curriculum, that young people also experiment with a whole cadre of substances beyond fentanyl, whether it was intentional, many are unintentional. So just being aware that, there's a wide degree of drug use that can occur recreationally within younger people. So more than happy to specifically add fentanyl, but that was kind of our thinking for that as well. I don't know if you have anything else to add, Amber.
No.
Okay, Brad?
Yeah, thank you. I would think that maybe we, in addition to adding fentanyl, maybe just adding like new and emerging drugs, because I mean, it's fentanyl today, but who knows what it's going to be tomorrow. The other reason I really appreciate and like this recommendation is because, like all of us on the phone, we were once grade schoolers, and grade schoolers will inevitably, hopefully, become adult. And so it's about changing the culture and about changing the understanding. And so it's not, for me, it's not just about it's very much about youth saving youth's life, but it's also about changing the culture for the long-term trajectory. So I really like and appreciate this recommendation.
Thank you. Before we jump to you, Michael, Tim, did you address the Good Samaritan law? Was that explicitly mentioned?
Yeah, that would. Yeah, thank you for bringing that up. That again would be boiled into the curriculum on that. And serendipitously, Caleb will be talking about the Good Samaritan law later on today in another recommendation. So thank you.
All right, Michael.
Yeah, Tim, I believe you said that you mentioned OSPI, and I'm not sure if that was if OSPI was consulted in the development of the recommendation, or the recommendation was to consult with them at a later time.
So we had a representative from OSPI attend a couple of our meetings, and that's where we got most of our concerns and our considerations from.
Okay. All right. So they had a chance to review the safety first curriculum.
They had a chance to review what we put forth. Do I know objectively that they reviewed the curriculum in detail? No, but I know that we gave them the information.
Okay, thank you.
Yep. Yep.
Okay, any other comments, questions, concerns before we move on to vote? All right, Senator Braun.
Yeah, thank you. And I missed the first part of this conversation, so I apologize, but I'll be the naysayer. I am sensitive to the idea that we want to keep people safe. And I also somewhat sensitive to the stigmatization issue here, but it seems to me, you know, part of the downside of doing that is normalizing the use of drugs. And we're saying, well, you know, kids are kids and they're going to do this. Well, that's certainly true of some kids, but it's not true of all kids. So in fact, now we're saying because some kids are experimenting and we don't want to, you know, screw them up forever, and certainly don't want them to hurt themselves long term. And I agree with that. We're going to normalize this and encourage the other, I don't know what the number is, I'm just going to make up a number, 50% of kids who are not doing drugs, certainly not some of the drugs we're talking about, by making this normalized. Look, these are kids that are very young. We don't allow them to smoke or drink. We don't allow them to go to a tanning salon by themselves, but we're going to normalize the use of hard drugs in our schools. That seems a little bit out there to me, and I think we ought to be extraordinarily cautious, even though we may agree on keeping people safe and certainly saving lives where there is you know, where I would say, personally would say, where poor choices are made. We don't want to know. I think normalizing this entirely is a dangerous thing. And I would caution against this.
I would just like to say really quick that you can't die from smoking one cigarette. You can't die from having one drink or going to a tanning salon, but you can die from using fentanyl just one time. The very first time you ever even experiment with it or even try it. And most of those experimental things are happening in peer settings with kids. So I would just say that it's very important that these kids are armed with information, because it's more likely than not, with the numbers we're seeing, that this is going to be an experience that they're going to have where they're going to either know somebody that's experimenting with it or that they're going to experiment with it. And also with the numbers we're seeing, it's disproportionate that that's the likelihood that they're going to die because they're not going to have the resources available to them to know when things are going really wrong and not just get scared and not act. That's all.
Okay, and Teresa, and then, okay, Teresa.
Yes, thanks. I want to tag on to what Amber was saying. You know, when I was in 6th grade, I was being taught about addiction. I was being taught about drugs, and I was shown the dangers of what could happen. There's nothing in this that says it's normal to use fentanyl. What it is saying that you should know the signs of overdose, and you should know what to do if you think somebody that you love is overdosing. That's all we're talking about, is straight education and increased awareness. We're not talking about saying, hey, using fentanyl is normal. Nobody said anything about that. It doesn't say that in this article. We're just talking about giving kids the tools they need so they don't die.
All right, any more comments? Okay. All right, Michelle, before we get into the vote, do you want to just review that process real quick?
Yeah,
I'm not sure that
definitely.
we did that.
So, yeah. So for those of you who were at the meeting last Monday, this will be familiar, but for those who were not, we've got 3 options that will count as part of a vote, and then you also have the option to abstain from voting. So within all of those, hopefully we capture each SURSAC member who's present. So a yes vote means I support this, I want it to be included in the SURS plan. A no vote means I do not support this recommendation, I do not want it in the plan. Defer means that you're open to discussing it at a later date, but you do not want it in the SURS plan at this time. Don't want it in the SURS plan. And then abstaining means that you're here, you're present, but you are opting to not vote on this recommendation. So this will auto tally as we go through. For example, if there's 6 yes, 3 no's, 5 defers, and then there's that, and then we may have a few abstains. So as you can see, that again, the abstain is not counted in the total votes, so that if we can get supermajority 60% from the people who are voting. So if there are any questions about that, happy to take those, and otherwise we'll move into voting on this recommendation. Okay. So if you support this recommendation and want it to be included in the plan, your vote is yes. Please go ahead and raise your hand now.
Okay, I'll go ahead and read those.
Okay.
Julian Saucier, Caleb Banta-Green, Addie Adwell, Amber Daniel, Cherry Candelario, Randy Flood, Teresa Atkinson, Sarah Melfi Klein, Sarah Gillard, Malika Lamont, Senator Dingra, Amber Leaders, Alexi Orr.
Great, thank you so much. You can put your hands down. And once all the hands are down, we'll go to the no vote. Okay, so if you do not support this recommendation, do not want it included in the plan, please go ahead and raise your hand now.
See 0.
Okay. And if you would like to defer this recommendation to open to discussing it at a later time, please raise your hand now.
Senator Braun and Kevin Ballard, excuse me. Just be it.
So 2 for defer. And if you are choosing to abstain, sorry, yeah, you can go ahead and put your hands down. If you are choosing to abstain from this vote, go ahead and raise your hand now.
We have Chad Enright and Michael Langer.
Great.
Thank you.
Thank you. Thank you so much. Looks like we got 87% yes on that one. And now we can move to the next agenda item.
Do you want to go back
or
to...
go back to, yeah, I'm sorry,
yeah.
Go back to the recommendation number 9. So is Alan Muya on the call now?
Do not see.
Okay.
Shall
So
we move
perhaps
on
we
to
can,
13?
yeah.
Okay.
Mm-hmm.
And that is you, Michelle?
Great. Yes. So there's section 1.3M in 5476 specifically outlines some a need for recommendations related to data collection for specific pieces of data. And so the data subcommittee put together this recommendation for creating an infrastructure that would pull existing sources of data together to allow that reporting process to happen, and also make it possible to start collecting data that is not necessarily being collected yet. So I've got Mark Cook and Jim Mayfield on as well. I hope with us at the meeting today who can help answer some questions about this one, but I'm happy to provide an overview. So the recommendation is to build upon and provide ongoing funding for a data integration infrastructure that can receive and analyze standardized data gathered by law enforcement, courts, prosecutors, the Recovery Navigator Program case management, behavioral health treatment services, and recovery support services to meet the mandates of Section 1.3M. And I'll go ahead and share my screen now so we can see the recommendation together. So 1.3M says, asked for recommendations regarding the collection and reporting of data to identify the number of persons that law enforcement officers and prosecutors engage related to drug possession, and also disparities across geographic areas, race, ethnicity, gender, age, sexual orientation, and income, and that those recommendations shall include, but not be limited to, the number and rate of persons diverted from charges to the Recovery Navigator services or other services, who receive those services and what type of services, and who are charged with simple possession and who are taken into custody. So really trying to figure out, after a point of engagement with law enforcement, what's happening to folks, what are the demographics of, the folks going into custody or being charged versus, and or going to Recovery Navigator services. And so as we took a look at the existing sources of data for these things, what we ended up landing on was that we need an infrastructure that can draw from existing sources and also provide a way of analyzing and reporting those that can take a look at the demographics as well and track people on an individual. Well, I don't think I have to be careful about language here because I'm not the expert with this, but to get the individual level in terms of the demographics needed for that kind of reporting. So here's the table that may help. So at a minimum, these are the different data elements that we would want to be collecting with this new data infrastructure and some potential sources of that data, which is very, very similar to the language that was used from the bill. I mean, that's where we took it. And so here, if simple possession remains categorized as criminal activity, then these pieces would also apply or continue to apply. So I'll just leave it at that as the high level overview for now, and start fielding questions. And if there's something I've left out that's essential, Jim or Mark, please feel free to hop in now. But otherwise, open to questions or concerns about this one.
Malika, go ahead.
Wouldn't you also want to have lead and arrest and jail alternatives data put in there, since HCA has been funding those for years?
Yeah, that's a great point, Malika. I think that's mentioned some elsewhere in the recommendation. Sorry, was someone speaking, wanting to respond to that? Okay, sorry, I thought I heard someone say something.
Oh, this is Mark.
Yeah.
Hey, Malika. I think that would be it's over inclusive in terms of like other service providers, and LEAD is specifically listed as in part of the background and supporting data as an example of doing this type of data infrastructure properly. So I would say that it's included in just terms of the overall recommendation of having various behavioral service providers included in there, but that's my take.
Okay, because I mean, that is a strong example of how a public safety program has already been like doing this work with this, and the state has funded it. But I thought I had seen it in there. I just didn't hear you mention it, Michelle. So I thought maybe something had changed. Thanks.
It's definitely in there. We definitely had a lot of conversations around the RNP program, specifically LEAD and GRACE in some areas. So we definitely will not leave that out. But thanks for letting us know.
Thank you. And Chad? Chad Enright?
Sorry, I was chewing something. I just want to echo the point that I think Mark made in the comments about funding and making sure that this isn't, if this is a recommendation that the legislature follows, that it's not just an unfunded mandate, and that for some agencies who maybe already have the technology to gather this data quickly, it may not be too burdensome on them, but there are a lot of different agencies and departments across the state that just have different systems and different limitations on the data that they can collect, and so sometimes it is really labor intensive, and so having a funding element added in there, and obviously we don't need to be specific at this point, but maybe just something in there that the legislature will fund this data collection, something like that.
All right, thank you. Any other questions? Caleb.
Hello again. I want to clarify my understanding. I just want to make sure I understand that this recommendation is about individual level client data. Looks like it is, because it talks about identifiers, and trying to get some integration around identifiers so we can actually do individual level analyses. Oh, good, Jim's there. You're saying yes? Because my next part of this, if only RMP is listed. I'm going to not try to follow the chat because I can't do that. So the question is making sure this is individual level data and trying to assure that. And then my other question is this going to have adequate staffing support? I hope the answer is yes, to places like RDA that do have outcomes data, so that we have the process data, the actual utilization data, and we can combine that with the outcomes data. And is there staffing for that?
Jim, I'm assuming you have a direct comment for Caleb on that?
Yes.
Right,
no, there is no funding or staffing to support this effort other than our time right now with these sorts of meetings. And whether or not actually it would be RDA doing this work is not something that has really been addressed. But it's a significant effort to integrate these data and do the reporting that we're talking about. So I'll just echo the previous comments. That is this integration process is a fairly significant investment. But if we do it, Caleb, we will be able to do the things that you're asking about, including quasi-experimental evaluation, the kind of work that we need to do on this stuff.
Yeah, and I'll just chime in, and Caleb, if you were asking if the recommendation was asking for funding, that for staffing, that is part of it, and in the approximate financial support and staffing needed, there's some mention of staff there and the different kinds of staff that would be needed to do this work.
All right, thank you. Chad, was your hand still up for comment?
Nope, I'll lower it. Thanks.
Yeah, thank you. Okay. Any other comments, questions? All right, Michelle, should we move to vote?
Yes. So as I am pulling that sheet up, If you could begin the hand raising for the yes votes, if you support this and want to see it in the plan, please go ahead and raise your hand now.
Okay. We have Teresa Atkinson, Donnell Tanksley, Caleb Banter Green, Chad Enright, Sarah Melfi Klein, Eddie Adwell, Kevin Ballard, Julian Sautier, Sherry Candelario, Malika Lamont, Senator Dingra, Alexi Orr, Amber Daniel, Amber Leaders, and Brandy Flood.
Thanks, everybody. You can go ahead and lower your hands. And once all hands are down, we'll go to the no votes. Sorry, Tink, I think I lowered your hand and then you put it. Okay, yeah, thank you. So if you do not support this, don't want to see it in the plan, please go ahead and raise your hand now.
See zero.
Okay. And if you're open to this, but would like to defer to conversation at a later time on it, please go ahead and raise your hand now.
Zero.
Okay. And those of you who are abstaining from this vote, please go ahead and raise your hand.
Michael Langer.
Okay. Well, that seems conclusive. Thank you so much, and we will go ahead and move on to, as soon as we can see if, yeah, go ahead.
Is Carmen, I have Carmen on my agenda for 9. Carmen's here.
And that's the recovery helpline, right? We were,
Asset
yeah,
mapping
Carmen,
tool,
if you're open, so yeah, Carmen, if you're available and open to do that, I don't think that had been, we were working out who was going to do what still. So yeah, no, that's all right. We can, Carmen, would you be open to doing an overview of that one, or should we move on to the next recommendation?
I'm willing to do as much as I feel like I'm able to do. I was only on one very short meeting for this, so yeah, I'm like I said, I'm able to share what I'm aware of, but I don't feel like I have an extreme amount of knowledge to be able to give a strong overview. And Michelle, if you or Brianna are on here and want to fill in gaps, or we could certainly go that route. So you tell me what you want me to do.
This is recommendation 9, correct?
Correct.
Right,
All
right.
Great, thank you.
Yeah, yeah, Carmen, how about you go ahead and get us started, and then Brianna and I can help fill in where we can. Yeah.
Great. Okay. So my name is Carmen Long. I am Executive Director for Truly Motivated Transitional Living out here in Yelm, Washington. We've been operating recovery residents for the last 17 years. And I'm also a founding member of the Washington Alliance of Quality Recovery Residences. So I was on our committee meeting last week, meeting with Brianna and Alex and Michelle and some other folks. And I had just made some comments on what I know of the Washington Recovery Helpline. I was really happy to see when it came out. I said it's been a great tool for us. I gave an instance where we had a former resident call and was desperately trying to seek a detox for a friend who was in crisis. And I was able to send her that PDF, and she emailed me later on that day and said they were able to get her into a detox program that were on that PDF. So my comment was, I think it's a great tool. Obviously, it's not a perfect tool. There's always room for improvement. And my biggest recommendation was that we just really make sure to keep the resources that are on there updated, and whatever that takes as far as manpower, staffing, to make sure that we're getting real-time information on there and keeping those resources, making sure they're up to date and not outdated. Still, you know, functioning agencies and people that are offering resources was my thought on that. Just the idea behind that is a bad reference for an outdated facility is actually worse than none at all in my perception. So that's probably about as much as I can say on that one. Thanks, Michelle.
Yeah, thank you, Carmen.
You bet.
Brianna, if you're on, I don't know if you want to add to that at all, and if not, we'll go ahead and open to comments and questions.
I think we made edits to the recommendation. Can we pull it up so we can, yeah, I think that might be helpful.
Yeah.
I don't know how many were able to look at this, but the highlighted sections were the parts that we updated to incorporate the comments that were given at the last meeting, and by I think Caleb emailed us afterward to give us some feedback and updates that we've incorporated in here and added to with the subcommittee. As you were talking about, Caleb, that it'd be great if there was a referral, if this was also part of a referral system. And so we wanted to add that part in here to make that more expansive than just a locator tool, but to also help with getting people connected through referrals. Can scroll down, Michelle. We included that other states and other counties are also providing these types of services. There's also the Get Help Now provides it in other areas and states across the United States, and we're just trying to make sure that we have one that's very valuable here in Washington for our Washingtonians. I incorporated about the infrastructure for those pipelines from existing sources into one to provide more of like an illustration of what that process would look like, to have real-time updates, because that's one of the biggest things, is to have real-time updates. And by creating those pipelines, and we've spoken with Atlas Shatterproof and we've spoken with Third Horizons, and that was their foundation, was to create that infrastructure, to create those pipelines, to get the most updated real-time data as possible. And again, incorporating that legislative mandates for those originating data sources would be really, really helpful to make sure that everything is up to date in real time. We also updated the funding because we knew it was going to take more money to not only add the referral system, but to also make sure that there was staffing, and also updating the campaign and ads to reflect the same amount of funding that takes for other campaigns as well. And any questions or comments?
Caleb.
Hello yet again. So I'm still confused about the scope of this. The document refers to a companion law that's very focused on inpatient and withdrawal management and beds. So I see that part of it. I actually don't see the word outpatient in there anywhere. I see a mention of SSPs, but not health hubs, which was a recommendation they went forward. So I'm confused if this is really a bed locator or if this is supposed to be all SUD related treatment services, whether that's in specialty addiction treatment or whether it's primary care like we see in the opioid treatment networks, which is mentioned. I'm really unclear on the scope of this recommendation. If someone could please help me with that, I'd appreciate it.
So further up top, it does talk about the peer clubhouses. It talks about all services. We didn't incorporate health hubs because again, it was just passed, so we didn't incorporate that, but yes, that would be a tool. And I tried to word the language for current and future data tables. So that would be like a future data table or data source that we collect from to provide information on. We want care access points, just all care access points for people with SUD. So it's not, so we're trying to make it as the language as broad as possible to incorporate all those sources. So though we didn't line them out specifically, because I think there's plenty that we could, I wanted to just make the language very broad so that we can incorporate all of those.
And that $1 million would go for people to staff phone lines or to build the data infrastructure or both, because that's, you know, maybe 8 or 10 people to monitor a system that could have, I'm just picking a number off the top of my head, over 1,000 different sites that would need to be updated, particularly if you're incorporating primary care access points and health hubs and such. So just trying to get a sense of scale.
So the funding piece just talks about what the infrastructure is. The other section talks about the FTEs. That's a different, would have to be a different pocket of money. The $1 million is just for the developing the infrastructure and the system, and then continuing to maintain it.
So I'll just note, I read Third Horizon's report and heard them present on it. It was very abstract and theoretical, and it was not well based on our data. So I just think that's important to consider that, but recognize it was sort of a generalized model they've used nationally. So it sounds like this is more for the data infrastructure, but I would really encourage you to think about it, a massive complement of staffing to keep something like this actually up to date. I do think it's necessary. And I do know that however long ago that was, Michael, where, you know, you guys advertised around treatment medications and recovery helpline. They had a big spike in calls for about a month and then it disappeared. But if we're going to make a sustained effort in this, you know, it has to be really substantial. And I'm just concerned that it's not substantial enough, particularly on the staffing side. I mean, you know, and again, I helped build the original system, and I was trying to build a more passive data-oriented system, and it just isn't sustainable. You know, there has to be a lot of FTE behind this type of work to keep it up to date, as things are changing quickly. So I don't know what else to say, except that it sounds like you're trying to keep the scope broad, which is great, but the staffing, there's no reason to build it if you're not going to build the complementary data to actually staff it at the helpline or other places and call centers. The data infrastructure is useless without that. So that really needs to get called out as a substantial amount of FTE to support this, because it has to, as was said earlier, it has to be correct. Otherwise, people will just give up, and that's not when you want people to give up, right when they're trying to get help.
Well, the nice thing is that if this passes through legislature, it will go through many, many rounds of bill analysis and review by our internal folks, and we'll be able to provide support. Again, I placed in here that these are estimations, and I also incorporated your comment about substantial staffing will be needed. And so I don't think we need to do that right here, right now. I think this is broad enough to get it moving forward, and then when it gets to the actual building phases through legislature and policy, I think we'll be able to add what it really is required by by many reviews by our financial analysts, who will probably have more accurate numbers than we can come up with here.
All right, any other comments? Questions? Okay, Michelle, ready to vote?
Ready to vote. So if you are in support of expanding the Washington Recovery Helpline and asset mapping tool as per this recommendation, and including it in the plan, please go ahead and raise your hand now. So I pull up the tally.
Okay, we have Teresa Atkinson, Chad Enright, Julian Saucier, Kevin Ballard, Caleb Banta Green, Sarah Melfi Klein, Amber Daniel, Cherry Candelario, Addie Adwell, Sarah Gillard, Randy Flood, Malika Lamont, Alexi Orr.
All right, thanks everybody. That was 13 total. You can go ahead and lower your hands and then we'll do the no vote. Caleb, I'm lowering your hand. All right, so if you are not in support of this recommendation and don't want it in the plan, go ahead and raise your hand now.
See zero.
All right, and if you're open to this but would prefer to defer the conversation on this topic for another time, please go ahead and raise your hand.
Senator Dingra. All right.
All right, and if you're abstaining from this vote, go ahead and raise your hand.
Michael Langer. And Amber Leaders.
All right, thank you, everybody. All right, next recommendation. I think we're on to
15. 15,
yes, 15 now. Yep.
Okay.
So Jessica Blows will be providing the overview for this one. Jessica, are you on?
Yes, I am here. Hi, everyone. Good morning.
Morning.
Would you like me to screen share the item, Michelle?
Yeah, I can do that, or if you can, that's great too.
Sure, I think I can do it. Let me pull that up. So hi, everyone. Again, good morning. I'm Jessica Blows. I am our state's opiate treatment authority. I had the really good fortune of assisting the treatment subgroup in creating some recommendations for opiate treatment programs, specifically in rural areas, with a goal of looking for changes that could be promoted that could help increase access to opiate treatment programs. Always like to start off by saying when we're talking about opiate treatment programs, we're talking about settings where medication to treat opiate use disorder, such as methadone or buprenorphine, is actually dispensed from the facility. We're talking about what has historically been called methadone clinics. Also, I'm going to continue to use this term about a medication unit. And a medication unit is just the term in federal law that describes a satellite clinic. That's a smaller version of an opiate treatment program that exists off-site of a physical OTP site. So let's get into the recommendations. This had several different sub-recommendations. The first part of them really focus on recommendations that don't necessarily require spending of resources, but would require some regulatory changes. So the first recommendation is to have our colleagues at the Department of Health work with OTP stakeholders to develop basically a way, like rules as well as licensing ways for opiate treatment programs to have medication units. So again, we currently have state rules and application and licensing for any provider who wants to have a full-on opiate treatment program. We also have resources already for mobile opiate treatment, but we don't necessarily have state rules in place or a licensing process if there was a desire to have any medication units co-located in community settings. Could be anything from hospitals, medical primary care systems, pharmacies, FQHCs, correctional health settings. This is something that's allowable under federal law. It's also something that many other states have. But for whatever reason, we in Washington don't have it. So again, we think to try and get opiate treatment programs out there, we should just have state rules and licensing opportunities in place to get as many types of opiate treatment programs and methadone access as possible. So that's one recommendation. We also have recommendations to basically look at RCW 3670A.200 and also the corresponding WAC here to make sure that opiate treatment programs are clearly noted as being an essential public facility. This would help city and county legislative authorities who oftentimes have questions about how should opiate treatment programs be zoned. They oftentimes have to have moratoriums put into place while they work with their planning commissions to try and determine if an opiate treatment program should be included. The existing RCW and WAC do make reference to substance use facilities being considered essential public facilities, but again, opiate treatment programs, for whatever reason, just have historically had all kinds of questions. And again, as the state opiate treatment authority, I actually get calls multiple times per year, again, from city, county, and tribal legislative authorities, trying to get more information. I put an example in here, even in recently in King County with mobile opiate treatment programs, we had questions about should they be zoned as food trucks? Could they be, should they be required to be considered a permanent structure, even though it's a mobile facility? So again, I think just having a bit more clarification and clarity in those RCW and WAC would actually help a lot of city and county legislative authorities and their planning commissions to know what to do. We also have a third recommendation, again, also around changing some RCWs. There's RCW 7124-590, and it does include an element that says county legislative authorities have the ability to cap the patient census at opiate treatment programs at no less than 350 individuals. So our group has actually recommended that we consider striking that language. Because again, for other types of substance use disorder behavioral health agencies, which is what an OTP is, there is never any mention of a patient census cap. And again, if we're trying to increase care, we want to be serving lots of people. So again, just for parity's sake and to remove and help bring more equity and removal of stigma, trying to strike that language. And then again, could also reference what we talked about before. They're essential public facilities and should really be just treated like any other behavioral health agency. There is also a requirement in state law that the Department of Health have a public engagement process, including a public hearing that Department of Health actually has to facilitate in the community in which a proposed OTP seeks to operate. So these public hearings do happen for every single opiate treatment program, but the reality is the Department of Health is legally required to license any qualified treatment provider. And oftentimes they go to these public hearings and receive comment. And one of the main questions that comes up from community members who attend is there going to be a presentation that even describes like what is an opiate treatment program? Is there an educational component? There is not usually an educational component built in. So we actually have recommended that we consider removing the public hearing process and instead replacing it with a community engagement process that could seek to reduce stigma by having basically education be shared about what an opiate treatment program is and how to share that this is an evidence-based treatment and how it has really great patient outcomes. And again, actually removing the public hearing requirement because OTPs do not require a certificate need of our state. And again, they are the only substance use treatment facility, that's a behavioral health facility, that requires the public hearing. So again, bottom line is we need to treat them as similar as we do to other healthcare facilities, and we would never have public hearings for outpatient behavioral health, inpatient, or office-based opiate treatment. So why are we doing it for OTPs? So those are the first several recommendations, and again, really just focus around updating and modernizing some of the RCW and WAC that could help have new programs. And the last couple of recommendations really are just saying, if the governor's office or the legislature are interested, there could also be possibilities to fund capital construction costs to help bring OTPs specifically to rural communities and or in places specifically in central and eastern Washington. We did talk about how Department of Commerce been given funds by the Washington State Legislature in the past to help specifically with capital costs for things like recovery housing and transitional housing. So there is already kind of a precedent and model in place for using some of the state's funds for capital costs. And again, we're only asking for capital costs because this service is already Medicaid and all other insurance eligible. Again, we also could, if there was a desire to have resources to help increase the number of, again, medication units, whether that's a freestanding place, a place that would be co-located within a hospital, again, primary care setting, a pharmacy, a FQHC, or as a mobile medication unit. And really, again, it's just a way to try and increase the amount of opiate treatment programs and methadone clinics in our state. And while we're here, I'm just going to screen share this little map. This was made for Washington State with help of the Pew Charitable Trust. And it shows where we have the opiate treatment programs in our state. As you can see, these dots, the little triangles, are opiate treatment programs. And as everyone can see, there are huge swaths of the state, especially in rural and eastern Washington, where there is no access. And the shading on the map actually shows for large parts of the state, it could take individuals anywhere from 2 to 3 hours to drive to an opiate treatment program. So as you all know, that is in no way helpful to anyone's recovery, and also could be, detrimental use of state resources, because I know, for example, Medicaid spends almost a third of its non-emergency medical transportation budget just to help individuals get to methadone clinics. So again, this is an example of why I think our group has really focused in on this as one goal. And we've tried to, again, include some strategies that should be cost-free, but again, just require updates to RCW and WAC, but then also some options if there was the opportunity for investments. I will pause there.
All right, questions? No questions? Okay, Michelle.
All right, so if you are in support, we're just going to move into the voting process now. If you are in support of this recommendation and want it included in the plan, please go ahead and raise your hand. And thank you, Jessica, for that great overview.
Yeah, thank you. Yeah. All right, we have Caleb Banta Green, Senator Dingra, Amber Daniel, Sarah Melfi Klein, excuse me, Sarah, Julian Saucier, Teresa Atkinson, Malika Lamont, Addie Adwell, Sarah Gillard, Rep Davis, Chad Enright, Shara Candelario, Alexi Orr, Brandy Flood, and Donnell Tanksley.
All right, so 15 total counted there. Feel free to lower your hand now. Brandy, I'm lowering your, oh, you got it, okay. Great, so if you do not support this recommendation, don't want it included in the plan, please raise your hand now.
Seeing zero.
Okay. And if you're open to this idea, this recommendation, but prefer to have the conversation at a later time, go ahead and raise your hand now to defer.
See zero.
And if you are abstaining from the official vote on this recommendation, raise your hand.
Michael Langer and Amber Leaders.
Okay. All right. Thanks so much, everybody. I think the next agenda item, next recommendation to look at is recovery housing, licensing, and zoning laws from the Recovery Support Services Subcommittee. And Sherry and Carmen, are you covering this one? I believe so. Sherry, you look ready to go.
Yeah, I'm ready to
Okay.
go. Okay, I am the co-chair of the committee, and I'm also co-founder of Kate's House Foundation with my husband, Frank, and we do level 2 medically assisted treatment homes in King County. One of the issues we have find is we purchase our homes and we treat people coming out of Department of Corrections, King County Drug Court, hospitals, and many from homelessness. One of the major issues we have is zoning. The neighbors don't always want us there. In 2017, I co-founded Walker with Carmen and Alan Moya and several others, and we brought the NAR standards to Washington State. And basically, NAR breaks down into 4 levels of housing. And level 1 is typically the Oxford House, which is democratically run. Level 2 is the medically assisted treatment homes where people can be on medication for their substance use disorder. We do level 2 homes. And what the purpose of this recommendation is to really kind of allow us to be in neighborhoods, whether we're purchasing homes or we're buying homes. And by, equating ourselves within our standards, it gets rid of some of the antiquated language where a recovery home is synonymous with an adult family home. It's a totally different entity. We're trying to really provide access to housing by making a statewide initiative that we're following the NAR standards, and we're able to be welcomed in our neighborhoods. And so the standards we're using are already established in the state, and we want to make it that everyone can have housing, and this is really protects recovery housing operators. Carmen, do you have any comments? Alan Moya, anybody else? Oh, there you are. Hi.
Carmen's on.
Carmen.
Here she comes.
Okay.
I'm here. Sorry, I had 1040 down. I've just had my volume down and my camera off.
That's okay. Do you want to go ahead and discuss how it's affected you with as a housing provider?
Can you give me some context on what you were just sharing, Sherry? Because like I said, I had 1040 down, and so just bring me up to speed on what's been shared.
Oh, so basically, I discussed using the NAR standard for level 1, level 2 homes to allow us to be in any neighborhood.
Right. Okay. And that's coming under the zoning piece?
Correct.
Yeah. So, yeah, I can speak to that real quick. And just, serving on Walker and having lots of different conversations with different providers and operators across the state. I know Alan and I spent some time with the gentleman in Renton who's trying to get a really great program off the ground up in Renton, and the city is just not allowing it to happen. And so, we run into these different things depending on where you're at as far as zoning and ordinances and different things like that, that are just not allowing recovery residents to come and do, what we need to see them do. As far as the NAR definition of recovery residences, I just feel like that's something that we, as a state need to uphold. And then we've been given these definitions, and that's what Walker, obviously an affiliate of NAR, we have to adopt their same language, and we're the accrediting body for Washington State. So just a similar language as far as what is a recovery residence, the levels of care that are really, really important, because that gives people a choice in what level of care that they feel like they need. And so if we could all adopt the same language as far as what a recovery residence is, that's just going to benefit the folks that we're trying to serve.
And I want to piggyback on that. It shouldn't matter what zip code you're putting housing in, because some zip codes will allow up to 8 unrelated people, which makes it easier to provide housing. But others restrict the number of people that are unrelated living in a home. And they use that to basically zone out recovery housing.
Right. Yeah. Yeah. And I think we talked about too on this recommendation, just a general educating different state and, you know, not state, but city governments on what a recovery residence is. I think it's still kind of a, oh, wait, what's that? What does that mean? What does it do? And so we talked about briefly, just an education piece on what I think everybody knows what inpatient treatment is, you know, hands down. That's kind of a no-brainer. I think people go, oh yeah, treatment, you know, but recovery residences are, unless you've had an education on them, most, you know, city governments, they don't necessarily know. Some do, but not all do. And
no, that's really important.
Yeah.
So Carmen, this is Alan. Can I pile on for a second?
Yes, pile.
Yes, pile on, please.
So Alan Mua also from Walker, and a recovery residence operator, and our experience across the state has been that, as Carmen said, that municipalities treat residences really differently and want to call them boarding houses or adult family homes or other categories that just don't fit. And specifically, what those categorizations do is they impose requirements on those homes that go far beyond what a single family home would be required to put in place, which is in direct contradiction to the Fair Housing Act, which places recovery residences at the same level as as single family residences. And so for instance, if you're a boarding house or you're another kind of facility, there's sprinkler systems involved. Adult family homes need to be ADA compliant for very good reason. But recovery residences don't need to be, and actually it would be prohibitive to do the kind of work on those homes to make that work. So just the understanding at the local level, if there was some statewide understanding of a category that then could be communicated to folks in those sort of zoning, that are making zoning decisions and placement and so on, and so that operators could be in partnership with their municipalities rather than kind of in opposition to them in terms of their existing standards and so on.
And
right, I'm done. I just thought to throw that in there. That's what we run into.
No, that was critically important. I wanted to piggyback on that one. We have several recovery homes in King County, and it is not unusual for the neighbors when they find out what we're doing, because we're a bigger organization, to call the planning department and try to shut us down before we open up. And luckily, where we have most of our homes placed, the planning department knows us very well because we've been doing this for 7 years. But it's really a challenge to not have the protection. When we had our first interaction with the planning department in 2016, they called us a group home, said, you can't do what you're doing. It will be at least 6 months and you have to go to the city council. But we educated this zip code, but it really has to be statewide. And I think the NAR standard of defining what a recovery home is, and if we can all rely on that, would make it easier for more of us to open more homes statewide.
Yeah, and just to piggyback on what Sherry just said, making it easier for us to open more homes statewide. For those of you that don't know, recovery homes, sober living homes, recovery residences, whatever terminology you're familiar with, is really where the magic happens. It's where people recover. It's where people get jobs and discharge DOC supervision and get their kids back and get their licenses back and get out of the court system and start living life and, contributing to our, state rather than being a burden to it. It's really where the magic happens. And so the more recovery homes we have, the more people in recovery we have, the more we can start really, doing something about this major issue that we have facing us here in Washington State. And I don't know if we talked about the outdated language as far as licensing, being licensed as a business goes, if you guys did that part yet of this recommendation, or if we just talked about the zoning issues. Did you guys get to that part yet?
We did not.
Okay, well, I won't jump ahead. I'll wait my turn.
Oh, no, you're fine. Go ahead.
Okay. Well, when I was initially on this call, I shared with our group that because we got licensed as a business 17 years ago, and the only category I could find to fit us under was a boarding home. And I just said, it'd be really great if we could have specific language for recovery residences in our Washington State laws and RCWs. I know we have definitions for group homes and boarding homes and mental health, all these different services. But we really need language specific to recovery homes. And I would love to be licensed as a recovery home instead of a boarding home. And so that was just an example that I gave of, is that something that could be done here while we're making these recommendations. And the other thing that was interesting that I learned was in our county, we would be actually considered an adult family home, and there's a cap on how many people you can have in an adult family home, and that's 7. So that becomes really restrictive when you're trying to run a recovery residence as a single family residence.
Michelle, there's a
I
question.
don't know if anybody else, Sherry or Ellen, has any places they want to fill in there.
Yeah, a couple of things in the chat here. Brandy asked, can individuals on methadone stay in your recovery housing?
Our level 2 MAT homes we house for King County Drug Court, the majority of people are on methadone. And the other issue with King County Drug Court, they actually they pay for people to stay in our homes, and they will pay up to 2 years.
I'll chip in and just say that answer varies a fair amount across the state, although there's a growing number that have, through our educational efforts, moved in that direction and are allowing all 3 forms of medication-assisted treatment. And so those are, and we continue to educate on that quite regularly. And we believe that there will be case law in place anytime that will make that just a done deal in terms of in the eyes of both national accrediting agency NAR, as well as we would need to follow anything that comes down. So just to be really plain, it will likely before long become there's many interpret it this way now, but formally illegal for folks to turn down folks who are on medication assisted treatment of any kind. So again, many interpret it that way at present. We are following our the model of our national body who accredits us at Walker, that says that there's still room at this point for folks to say we don't have the support for people who are on methadone, and therefore we're not allowing it. We're not allowing residents to be on methadone or even Suboxone for that matter. That's a shrinking number anyway, and before long, we firmly believe that it'll be that in order to receive our accreditation, homes would need to accept residents, and they put themselves at existential risk if they refuse. So, longer answer to your short question, but that's the process that we're in at present.
All right, thank you. And Caleb puts up here in the chat, can you say more about why you mentioned harm reduction and how it reconciles with the language around substance-free lifestyle? You seem in contradiction.
Can you tell us more, Caleb?
Yeah, go ahead.
Go ahead, Caleb.
Well, I'm confused why you're mentioning harm reduction. I'm glad you're mentioning harm reduction, but given that, as you well know, about over 50% of folks who are in recovery continue to use substances, which means they need recovery and treatment and harm reduction simultaneously. But there's language in there around substance-free lifestyle, which to me suggests that people would be discontinued or discharged or kicked out if they continue to use. So I'm confused. I welcome the language around harm reduction, but I'm not understanding how it reconciles with the substance-free lifestyle language.
I think what I would say to that, Caleb, is that I think there's process going on there as well, and that we talk a lot with our operators about their return to use policies. And there's more and more understanding that, people know that addiction is a chronic condition that has relapse and recurrence of use as a part. And so many of us have adopted policies that are very different from what I would call the standard, for lack of just for shorthand, the Oxford policy that would be a 15 minutes and you're out kind of rule. Many of us have policies that differ quite a bit from that. And so there's a growing understanding of what harm reduction looks like. Is it more harmful to send someone back out to the street because they had a slip or because they, for whatever reason used again, than it is to figure out a way to keep them safe and the house safe at the same time. And so it's a harder thing to do, to have a policy that has some flex in it and some understanding of where folks are at and kind of makes case by case decisions. But more and more operators are I think coming around to that position. So there absolutely is room for harm reduction in present policies. So just saying that the goal is a substance-free lifestyle doesn't mean that doesn't necessarily equate to a policy that says that in every case someone's going to be removed upon first use or anything like that. Does that make sense? So we're in flux as a field right now in that area, and I think that's a good thing. Been good progress
and
made
Caleb,
in a number of our homes.
I would like to add, because we work with King County Drug Court, return to use is common because we're taking people from jail. And the drug court has a system in place that when someone returns to use, they provide a housing stabilization plan that they sign with the judge. Now, Kate's House was founded 7 years ago with the sole idea that we would not do 15 minutes and you're out, and we would do MAT. And we're just pleased to see that this is taking hold throughout the nation. But the drug court model, I think, is highly effective. People return to use, they work with their counselors, they set up an HSP, they're not removed from our home. And when they are removed from our home, they're typically removed into inpatient treatment.
Hey, if I could just hop in real quick too, I think
5,
I'm
8,
assuming
4, 5, 2, 8, 0.
I don't know what's going on here. Oh. Caleb, I think that you might be referring to the definition of recovery housing it says by reinforcing a substance-free lifestyle, and then 2 paragraphs above that, it talks about language should be updated to include inpatient, outpatient recovery residents, harm reduction, including SSP. Is that what you were referring to, the contradiction between those two?
Yeah, I'm referring to the whole document, that it's about
Right.
recovery housing, you're specific, including definition of substance use lifestyle. I appreciate the harm reduction, but I just, as I'm trying to understand how that
Right.
reconciles. And the point of harm reduction is that if you can't have an honest conversation about your use or your craving, you're not having a therapeutically genuine conversation with someone.
Right.
I also just want to note that people don't return to use because they were in jail. I just want to clarify that.
Right. So I will just try and speak to the part that I would tend to agree with you. The document is a little bit confusing. I think that the paragraph here that's talking about language being updated to include that list of services is speaking to what is an essential facility and what's already included under essential public facilities. And this recommendation is saying those things need to be added to be included as essential public facilities. So that's one piece. And so I understand your confusion on that, and it would be equally confusing to me if it was my first time looking at it. So that's one, there's a lot of different recommendations happening within one recommendation here, and I think that might be the misleading part of this. As far as the recovery residences description and definition, that's what is on SAMHSA's page and on their website in the definition of a recovery residence. And so that's what we've adopted. And that would not necessarily include harm reduction. Obviously, harm reduction is a whole different model of going about trying to come alongside people. So recovery residences are specific to people who are wanting to live a substance-free lifestyle. Harm reduction is a completely different model, and the two may not be necessarily in the same camp, but they've kind of all fallen underneath the same recommendation. So I can understand your confusion there.
Right,
I guess for our part as recovery residence operators and for Washington Alliance of Equality Recovery Residences, we would like the definition that SAMHSA has adopted for recovery residences to stand, because that's really what they are. And there's a lot of different approaches to helping people get well, and we understand that harm reduction is one of them, but we wouldn't put that into the same camp as a recovery residence, if that makes sense.
But within that, I think there's we shouldn't assume that, again, a goal of a substance-free lifestyle means a draconian policy around return to use policies. So really making some headway on working through that with folks. So just because we have a substance-free home doesn't mean that we can't treat somebody humanely and work with them toward that goal along the way, understanding that it's not a linear process.
Okay, I'm gonna jump in here, and Michael had his hand up. Malika has her hand up. Malika also had a question about what percentage of your homes have come around. If you want to check that out too, we'll take Michael's comments first.
Blake, my comment's going to be more about what we're voting on. So I'd defer to Malika if she had a response to the more recent conversation, and I'll come back around.
All right, great. Malika, go ahead.
So just also, I would like to reiterate that it's not helpful when we try and pit the notion of recovery again or abstinence as something completely removed from harm reduction. The harm reduction, the umbrella of harm reduction does include abstinence. For people that it does work for, then that's great. Or people that are there, that's great. But in the harm reduction movement, we don't throw people away because they're not abstinent.
Right.
I'm super concerned that the language around having more inclusive housing options for people is a sidebar to what is being put forth in this recommendation. I don't like the way that it got laid out. So I share your concerns, Caleb. So I just wanted to, for whatever good it is, I'm concerned about this recommendation now that it seems like when people are going to probably at some of to Lauren's point, it's about all of these different things. It's not just about whether or not a person is consuming substances. It's about community, meaningful relationships, accountability, responsibility, setting and achieving goals, and mastering life skills. That is recovery. But my question was, what percentage have quote unquote come around to understanding that is what recovery housing is for? Because most of the places, at least where I live in Thurston County, if you lapse, you're out. So I'm just curious, statewide, what is that looking like as far as y'all are concerned?
Boy, Malika, it's a hard question to answer because we haven't surveyed on that specifically. What I can say is there's a lot of conversation around it, and I know anecdotally of a number of operators who have softened their policies and or started up with policies that have I would call real life policies around people returning to use, and that are about helping those folks achieve their goals. So anyway, I guess I don't have a number for you, but we may. It's a really worthwhile thing as we continue the conversation to do some surveying around where people are, just to get a sense statewide. I'll say that it has come along further in the last couple of years than I've seen it in a long time. So that's encouraging to us.
All right, thank you. And then the question around percentage of homes have come around. I'm not sure. Did that get answered?
Yeah, I just said I wasn't able to answer it.
Oh, okay, okay.
It's not a precise kind of measurement, and you know, it's a continuum, not a yes or no kind of a thing.
Okay.
Does that make sense? So there's kind of a range. There's the 15-minute rule probably on one end of the continuum, and on the other end might be something like nothing happens at all. Person isn't given extra support. We just move on like nothing took place. Somewhere in the middle is probably good policy. So
okay. Thank you. Sorry about that. Thank you for the clarity. Rep Davis.
Thank you. I just wanted to offer a bit of an analogy here. And I put a comment in the chat about, you know, thinking of housing for individuals with substance use disorder as a continuum, but this people's totally legitimate concerns that I agree with regarding recovery housing operators policies related to return to use. It reminds me of some gripes that I have with sort of the traditional SUD treatment infrastructure that still exists. For instance, individuals are kicked out of residential SUD treatment for a wide variety of reasons, and I've wanted to work on that for years. Individuals are not admitted to residential SUD treatment, or they're told that they need to there needs to be a cessation of the use of, for example, benzodiazepines, even if that was not a drug that they were can't think of a euphemism for abusing, but they were using that appropriately to manage mental health and using a different substance in a way that comports with SUD. My point is, like, the whole point of this group is to make recommendations, and the issues that I've mentioned around residential SUD providers, I'd love to work on, but it doesn't, you know, mean that we sort of like get rid of residential SUD providers. It's a process of continual improvement. And recovery residences, I think, are very similar. Like they've come a long way. Recovery residences, including Oxford, didn't used to accept individuals on MOUD, and now they do largely. So we're moving in the right direction, but I don't see these two things in conflict. It sounds like there's a forthcoming recommendation related to other types of housing for folks with SUD. Amazing. And also, recovery housing needs to continue to be an option. It's a really incredibly important, and for many, I mean, we have tens of thousands of people in recovery in the state of Washington, and the majority of them credit their long-term recovery to recovery residences as defined by SAMHSA.
Thank you. Michael.
Yeah, thank you. And thank you, Rep Davis and others for the conversation. I agree wholeheartedly that it is a continuous quality improvement process we're going through. And a lot of lives, I think, across the residents have been better off. I think a lot of movement, even in the Oxford arena, around the 15-minute in terms of people really helping people into treatment, bringing them back in quickly, supporting them through the process. And so I think look forward to more conversation in that vein. But I was coming back to the recommendation at hand, and I was hearing that there was a recommendation that we were asked to look over, but then I was hearing other things being suggested, and I just wanted to make sure before we vote that we're clear about what the vote's on. So, are there changes to what's written here that we're going to put forward at the call to vote, or are we voting on what the written part is? So it looked like the committee was adding a few things. I just want to make sure if that's a formal recommendation to add and then vote, or just vote on what's written now.
So Michael, this is Sherry. I think it's a huge improvement to embrace the idea of using NAR standards and NAR levels of homes as an initial first step, because right now, as my colleague Carmen stated, she was a boarding home. We were told to be group homes. What we're trying to do as an initial first step is eliminate the stereotype of what a home is and go with the national standards. It would just basically standardize the language across the state. And that really is the basis of the recommendation. And there's always room for improvement. I agree with Rep. Davis. There's so much more we can do. But I think if we could at least have Walker standards, these levels of home, which protect people in so many ways. And then the cities and the planning departments and the neighbors are not equating us with adult family homes and boarding homes and group homes, that we are in the official language. That would go so far to help those of us who want to house people.
So I think the short answer to your question, Michael, is that's what you're voting on, and there's more work to do in these other areas, and this recommendation doesn't cover some of the conversation we've been having, for sure.
Okay, thank you.
And I will just interject real quick to draw people's attention to recommendation number 18, which furthers the conversation around the continuum of housing. So this isn't the final recommendation related to housing. There's another one coming up that hopefully will be an opportunity to fill in some of the gaps that we're seeing that still need addressed. So just want to make sure everyone's aware of that as well.
All right, thank you. Malika, did you have another comment?
No, I just put it in the chat.
Oh, okay. Thank you. Okay. Anybody have any comments back from Malika's? I would like to address those barriers for all the residents that want to support folks, even if they do not adopt the abstinence-only approach. Okay, so let's go ahead and vote. Michelle, you already have it up, so go for it.
Yeah, so all those in favor of including this recommendation in the plan, please go ahead and raise your hand.
Okay, Senator Dingra, Julian Saucier, Sherry Candelario, Rep. Davis, Caleb Banta Green, Amber Daniel, Sarah Gillard, Lexi Orr, Teresa Atkinson, Addie Adwell, Brandy Flood, Sarah Melfi Klein, Malika Lamont. I think, yeah.
All right, thank you, everyone. You can put your hands down.
And I think Donnell Tanksley got in there as well.
Okay.
Thank you.
Yeah, the highest I saw was 13 total, so
okay,
that was okay. Just gonna start lowering hands now. Okay. And if you do not want this recommendation included in the plan, please raise your hand.
Chad Enright.
All right. And if you are open to this topic but want to defer the conversation to another time, please raise your hand.
C0.
And if you're abstaining from the vote for this recommendation, please raise your hand.
Michael Langer, Amber Leaders.
Okay. All right. Thank you, everyone. also, we're doing great on time, so thank you for that as well. And I think we're moving on to recommendation 17. And this is the Good Samaritan law that was mentioned earlier.
Looks like we have Amber and Tim. Thank you.
Thank you, Blake. Michelle, could you also pull this one briefly for a screen share? Thank you. I don't know if Amber is still available. Looks like she is still on there. There you are. Perfect, Amber. Do you want to go ahead and try to tackle this one, and then I'll fill in any potential gaps at the end?
Sure.
All right. Teamwork.
It makes the dream work. All right. This recommendation is to provide technical amendments to the Good Samaritan law, providing criminal protections for those currently involved in the criminal legal system, along with updating RCW 424-300 to provide employer-employee civil liability protections. So a lot of you know about the Good Samaritan law. You know that it says that, you know, people are protected from being arrested if they call about an overdose. And so there's a barrier for those who are currently involved in the criminal legal system from accessing emergency care in the event of an overdose, even with the protections of the current Good Samaritan law. The subcommittee identified a need for substantive changes to RCW 6950-315, medical assistance, drug-related overdose, prosecution for possession, to include prosecution for possession. So a person acting in good faith who seeks medical assistance for someone experienced a drug-related overdose shall not be arrested, detained, charged, or prosecuted for possession of a controlled substance pursuant to RCW 6950-4013 or penalized under RCW 6950-4014 if the evidence for the charge of possession of a controlled substance was obtained as a result of the person seeking medical assistance. And then a person who experiences a drug-related overdose and is in need of medical assistance shall not be charged or prosecuted for possession of a controlled substance pursuant to RCW 6950-4013 or penalized under 6950-4014 if the evidence for the charge of possession of a controlled substance was obtained as a result of the overdose and the need for medical assistance. So this is the part I believe that we added to it. A person or persons under subsections 1 and subsections 2 of this law will not be arrested, charged, prosecuted, or convicted, have their property subject to civil forfeiture, or otherwise be penalized for violation of a civil restraining order, violation of a protection order, violation of a no contact order, violation of probation and or parole, and or failing to appear for an existent warrant, non-violent, non-sexual charge. So the protection of this section from prosecution for possession crimes shall not be grounds for suppression of evidence and other criminal charges. There's a incident here where Seattle Public Library in 2022 was questioning the practices of prohibiting employees from carrying, administering drug overdose reversal medication, naloxone, through the Good Samaritan law. Though it offers some protection against criminal persecution for possession of a controlled substance, it doesn't provide adequate protection against civil infractions under those RCWs. It indicates only a person, including but not limited to a volunteer provider of emergency or medical services, who without compensation or the expectation of compensation renders emergency care at the scene of an emergency, and shall not be liable for civil damages resulting from any act or omission in the rendering of such emergency care. So we want to make protection for public and private employees in various venues, so that they're not going to get charged with any civil damages resulting of trying to save somebody's life with Narcan. I'm trying to see here. I just don't want to just read it out loud, but I don't want to miss any of the important points. Am I missing anything important here, Tim, that needs to be called out?
Yeah, so just, for folks scrolling up really quick, Michelle, what we're suggesting for the language change is, so anything highlighted in blue is something that we added. So the previous Good Samaritan law, an individual could be arrested and detained. They just would not be charged or prosecuted. So we're just trying to remove the ability for an arrest and a detainment to happen. As we all know, going to jail can be extremely traumatizing. While the individual may not be charged or prosecuted, they can still be arrested and detained. And then number 3 is new language as well, and it's really adopted from multiple states that have embraced a wider protection approach under the Good Samaritan law. And what I will say is that it was a difficult conversation to have around expanding protections. There was some ambivalence around expanding protections to individuals with protection orders and no contact orders. And so, I really think it's important that we acknowledge that that was a difficult conversation, but ultimately this recommendation is to reduce barriers for people to call 911 in the event of an overdose. And so, I just wanted to note that, we talked about this recommendation for almost 2 hours, and we set up a half-hour-long meeting. So people were really committed to working through that. And we did provide a link down at the bottom, which gives a matrix of the Good Samaritan laws throughout the state. And when you read through that, you'll see that 9 states did adopt this broad protection Good Samaritan law for a whole host of other preclusions to arresting, detaining, charging, prosecuting. Oh, yeah. And lastly, the last one is for employer-employee protections as well. I mean, we see that the liability law come up often, and some individuals use the liability law as a reason that they cannot provide naloxone and or carry naloxone. So again, we're asking the legislature to make technical amendments to the liability law as well, to expand those protections and reduce barriers to access to life-saving medication.
Got a couple comments in the chat. Brandy Flood noted, just knowing someone will be detained will deter folks from calling 911. And then Caleb asked, would this apply to the MIP language that was added a few years after 695315, and provided a link to that? I believe it's a link to that.
I do not know the answer to your question on off rip, Caleb. I'd have to read this RCW, but thank you for noting that. I'll go ahead and redo that.
Chad, go ahead.
Yeah, I mean, I think I understand the purpose here and the intent, but this is subsection 3 is really legal gibberish, and I've had to read it over and over and over again to try to figure out what it means and what it would cover. And I think what it does is something that I've just never seen in the law, where subsections 1 and 2, the state cannot use evidence collected when somebody takes somebody to the hospital, takes them to get services. The state can't use that incident as evidence, but subsection 3 reads that an unrelated case would have to get dismissed. If I'm prosecuting somebody for domestic violence and repeated violations of a protection order, 2, 3, 4, 5, 6 violations of a protection order, and they take somebody unrelated to that case to seek medical help, the plain reading of this, I think I have to dismiss my unrelated cases because I cannot prosecute them for a violation of a court order, a violation of a protection order. And I look at the makeup of this group and the legislation that created this committee, and there are a lot of voices. I don't think the legislature intended us to be fiddling with essentially domestic violence laws. We have no domestic violence advocates on this group. We have, we may have victims of domestic violence, but we have no, I guess, person dedicated as a victim of domestic violence. I just think this goes a lot broader than subsections 1 and 2. I really think there may be a way to word this narrowly, but the way it is, I have a difficult time with it. And I guess the other thing I would add is I understand the discussion about the Seattle Public Library, but where is the data from people not seeking help because of restraining orders or not seeking help because of a warrant? I'm sure it exists. I'm sure that there are anecdotal stories, but I'm uncomfortable making such a huge change in the law without some real data to it. So, that's my concern. The other thing I would add in terms of subsection 3E, failing to appear for a warrant, you know what? It's 2022. It is easy to get your warrants taken care of. You can do it on Zoom. You don't have to come to court anymore. So my sympathy for not taking care of warrants, it's just not the same as it was a year ago or 2 years ago or 3 years ago. So I think there's a really huge change. I don't think it's intended to be such a huge change. I think there are voices that aren't being heard here that are going to be significantly impacted. So, good intentions, but I think this needs to be narrowed down.
I will say, Chad, that was a lot of the conversation talking about what you're talking about, and there was a lot of expressed concern. So I appreciate you bringing that to our attention. Why we landed on including it is, with multiple people on the call, we understood the reality that individuals with restraining orders and protection orders still commingle and they still hang out. And if there isn't that protection, the other option is that person who has the protection order against them is fearful to call 911 for arrest, and then subsequently the protection order that's in place to protect that individual, they ultimately die. So it is a struggle that I think many people are grappling with. And that, like the thing said, what's the flip side? We have people not call and then that individual dies. So well aware of the concern that you expressed. It was the concern that we talked about for 90 minutes to 120 minutes. So, this wasn't easy for us, but we looked at the flip side, and the flip side could potentially lead to death.
Thank you. Donnell?
Yeah, so I also echo what Chad said, but also, when you talk about leading to death, A, B, and C certainly could also lead to death of a victim in that particular case. So, protection orders and no contact orders are orders from a court. So from a law enforcement standpoint, for me, it would be putting my officers in a very sticky situation. Do we enforce, don't we enforce, depending on the situation. So as written, for me, you'll see that I can't support this one. Thank you.
Thank you, Senator Dingra.
I'll just say adding the domestic violence components is challenging. Because we don't know what the home situation is. We don't know the lethality for the victim or for the person. And there are lots of other issues around it. I think it's way too broad for this committee to make that recommendation on domestic violence cases. And I agree with Chad that we do not have the right people in this group to be making domestic violence policy.
Great, thank you. Donnell, your hand is still up.
Sorry, I'll take it down.
All right, thank you.
And I just want to add, you guys, I know this is a difficult thing. I myself have been a victim of domestic violence, just as I'm a person with lived experience with substance use disorder, and I'm also a graduate of Pierce County Drug Court. Like I've been in a lot of these situations where I've been in a house using, and someone's been in an overdose situation, and somebody's like, call 911, and somebody else is like, don't call 911, I have a warrant. Don't call 911, you know, we're not supposed to be around each other. And I can think of 2 instances in my own personal opinion where a person has died because of that kind of an instance. And I agree, protection orders are super important, and they don't stop bullets. And unfortunately, you know, they don't stop people from, you know, contacting each other again in a, you know, voluntary manner, especially when you're, you know, in the same using circles and stuff. I know that when, from an outreach standpoint, also dealing with the homeless population, it's also very much an issue that people with protection orders are, or with warrants, are around each other because they're a community. And those are the communities that are being hit with overdose deaths the most, right? And also the least trusting of law enforcement, and also the least likely to call 911. So I guess the purpose of this, even though it's hard and it's, all we're really asking is that if somebody's called to a situation for an overdose, that's what they deal with. If that makes sense. And I do agree that we should have more, not only domestic violence advocates maybe on this call, but people with lived experience, like from Vocal Law and stuff like that, you know, that know what these situations look like and that can share their experience about, you know, what keeps them from calling 911. Teresa, I think your hand was up first.
Yeah, Teresa, go ahead. Thank you, Amber.
I guess for what it's worth, to argue the point that there are people here that don't have domestic violence experience, like what Amber was talking about. I also worked in the field of domestic violence for 10 years before I became a substance use disorder professional. There's a lot of stuff that hangs out with each other a lot. And I think there's probably more than you think, people that represent knowledge base and experience in this committee, whether we've been assigned the role or not. Like my role on this committee is a treatment provider, but I'm also a person with lived experience. I'm a certified peer counselor too. So like, I just don't want to assume that people on here don't have that background. I'm really struggling with this one, to be honest, from my experience with domestic violence, because I also hear what Amber and the rest of the committee are talking about. Like, I don't want people to die because they're worried about going to jail. I don't know how much we can really control that, or whether or not it's the right thing to do to have all of this in here. But I guess I just wanted to vocalize all of that for the discussion.
Thank you. Randy.
Well, I'm torn as well. I agree with a lot with Amber, but you know, it's really at the discretion of the officer who comes on the scene. And so even if we change all this, in certain neighborhoods, the officers are going to check everybody's name and do background checks. In other neighborhoods, they're going to arrive on the scene and thank that person for calling 911 and never check that person's record. And so we're not even looking at the racial equity aspects to this and who this allows for. And so I feel like in diverse neighborhoods or poor neighborhoods, they're not going to call because they're scared of the police anyway. So I'm really torn, but I just want to put that out there. Not every officer is going to come on the scene and check everybody's background because of his own personal or her own personal self-interest about who's in the room.
And I think that's what we're trying to do, Brandy, is trying to remove that subjective aspect of whether or not it's up to the officer of whether or not he's going to, check everybody's name in the room or not, based on, and it could be racially based, or it could be, based on just the neighborhood that they're in. We're just trying to make sure that it's that whoever needs to get 911 called if they're overdosing can get that.
All right, thank you. Great discussion. Any last comments before we move to vote? Okay, Michelle.
Okay, so we're going to move forward with it as written. If you are in support of this recommendation being included in the plan, please go ahead and raise your hand now.
Okay, we have Brandy Flood, Amber Daniel, Sherry Candelario, Julian Saucier, and Addie Adwell, and Alexi Orr.
So 6 total.
Yes.
Thank you. You can put your hands down. For those of you who do not support this being included in the plan and do not want to, defer it for further conversation, please raise your hand now.
Please include my vote, Kevin Ballard, as a no vote. Thank you.
Okay. Thank you, Kevin.
So we have Kevin, Donnell Tanksley, and Chad Enright.
Thank you. And for those of you who are open to this topic but want to defer conversation to explore further another time, please raise your hand now.
Okay, we have Rep. Davis, Teresa Atkinson, Sarah Melfi Klein, Senator Dingra, Caleb Banta Green, Sarah Gillard, and Malika Lamont.
Okay. Thank you. You can put your hands down. And then those of you who are abstaining from this vote, go ahead and raise your hand.
Michael?
Yeah, I'm not sure if it's working, but yes, abstain.
Okay.
Okay.
Michael Langer.
Right.
Amber's still on. Okay. Abstain. All right. Just one.
Yeah. All right. Thank you, everybody. And that brings us to the final recommendation for review today, which is the continuum of housing, a recommendation brought forth from the Recovery Support Services Subcommittee. And let's see, I don't know that we confirmed who would be providing the overview, but I'm happy to do that unless, Alan, are you want to do that?
I'm glad to, sure.
Great, thank you so much.
So I think the best thing to do, and you all have maybe seen it, I'm just going to read the first part of the recommendation just to get everyone centered here. So this refers back to the conversation we had both earlier in this meeting as well as several meetings ago when there was just recognition that the work that the Recovery Support Services Subcommittee was doing doesn't address the full continuum of housing needs. And so this recommendation would establish a funded statewide continuum of housing work group to develop a comprehensive housing plan that provides options for housing at the various points of intersection along the continuum of care for housing people who are currently using to those who are in recovery or seeking recovery, from immediate shelter to bridge transitional housing through long-term permanent housing. That might be the longest sentence ever written. It keeps going. But the big idea here is that that this subcommittee, as has been pointed out on a couple of occasions, was really working on the recovery housing end of things in terms of focus, but acknowledging that that the focus and the needs around housing are much greater than that particular piece. So acknowledging that the continuum of care is much broader than just the recovery housing portion, that the recommendation here is to have a group that works on that talks about housing as a whole instead of just the recovery housing portion. So the rest of the recommendation just provides some support and some thoughts about kind of where we are and some of the challenges that we're currently facing, as well as some things that the work group could address in its work. So essentially, the idea is to ask some more people to work on this, and especially people who have lived or living experience, both in seeking housing, being successful or unsuccessful in that, as well as all points of along the continuum, from people who are still using drugs to people who are in long-term recovery, abstinence-based recovery. So that's the recommendation in short. And if you want to look through the rest and have questions between myself and my colleagues on the committee, glad to field those.
Please, questions.
I like to remind people that this is the interactive portion of the program.
Thank you. We'll give it a minute here. Questions? Committee members?
I would just like to say that I appreciate the we've all had these conversations throughout the whole process about housing first and the continuum of housing and continuum of services, and recognizing that there needs to be like an official way to address this. I really do like this recommendation. I appreciate it.
Thank you, Amber. Any other comments, questions, concerns?
I think for the record, I guess it's just worth saying that those of us who are in representing Walker on this group and in the recovery housing field, and that's defined traditionally, as we talked about before, that we really are supportive of the whole continuum of care, and that understanding that people are in various places on that, and and that people need shelter and good, safe places to live, regardless of their choices or abilities around using or not. And so this, I think, recommendation backs up the idea that we can be a part of a larger, and we want to be a part of a larger conversation that includes us, but that isn't exclusively about recovery housing in the traditional sense.
Thank you. Malika?
So I just want to highlight that, everybody was hanging their hat on that this recommendation was comparable to the other one. The other one made comprehensive decisions, definitive decisions on about where money would go, what, law changes that would take place. This recommendation is to suggest that people talk about it, which is very, very important. And it is not as definitive as the recommendation that went forward earlier. And that is part of my objection and reason why I brought up that we needed to have the comprehensive continuum of housing as a part of that recommendation as well. And I think that Sarah Melfi-Klein's comment is very timely and important. There continues to be this dichotomy drawn, and for those of us that have been doing, and I'm not suggesting that other people have not been doing this for a long time, but for those of us that have been doing this for a long time, have seen the institutionalization of stigma. But we sit here and talk about we're trying to address stigma, but we are continuing to make very powerful decisions that are going to create definitive action that will benefit people which is good. I want people to be able to, if abstinence only housing is what works for them, I want them to have access to that. I also want there to be comprehensive access along a continuum so that people can be self-determined and progress in their life. So I don't want to, it feels real disingenuous to suggest that these recommendations were the same. And I appreciate that the Walker people want to have conversations, but it's not the same thing as the benefit that you will get financially from the previous recommendation that went forward.
I don't dispute any of that, Malika. I think this one is pointing to a broader conversation that needs to happen, which feels really important. That my hope is will lead to resource allocation to the broader spectrum, and I think we all hope that. And we all know that there are gaps all over the place, not just in the recovery housing arena. So fair enough. Absolutely.
And I will add, that someone had pointed out the funding component of this is so important so that action can be taken based on the conversations being had in the work group. So I just want to point out that the funding piece is meant to be very much emphasized here so that action can be taken and concrete policy changes or whatever else may come can be followed up with.
But it's an afterthought. That's my point. We made definitive action earlier. This is not definitive. This is, we're going to commit to having a conversation. Two different things.
There's a timeline in here that says that the conversation needs to be wrapped up ahead of, so that there are proposed implications for the 24 budget. So it doesn't call for what that is, Malika, for sure, but there's at least something in here that says that is a goal, that there would be funding implications to the work.
Not the same thing as having the housing readily available.
Fair enough.
All right, thank you, Malika. Rep Davis.
Yeah, thank you. I just wanted to offer, first of all, I appreciate the point Malika is pointing out, and I don't disagree. The one thing I would just say from my sort of legislative hat, looking at the whole state and the myriad of investments we're making from a capital perspective and an operating perspective, at least since I've been in the legislature, which is 4 years, the overwhelming majority of every housing investment the legislature has made for both operating and capital construction has gone to not recovery housing. It's gone largely to permanent supportive housing, which serves primarily individuals with substance use and mental health challenges, in addition to other challenges. And so I guess what I would just offer is, I almost feel like this recs in this area a little bit might be akin sort of to the DV piece, only because my colleagues, not me, but my colleagues, my amazing colleagues, are doing a huge amount of work around housing for individuals that have, significant challenges, substance use, TBI, et cetera. My colleague, Rep. Macri, passed a bill just this very year, 2022, House Bill 1724, and the subtitle is Ensuring Oversight and Coordination of Permanent Supportive Housing Resources to Maximize the Creation of High-Quality Housing Opportunities for People Living with Disabling Conditions in Communities Across Washington. That sounds a lot like the recommendation to create a work group. I just think that because most of the time that the legislature spends thinking about housing is actually for people who aren't in recovery, I actually think this is a much bigger conversation. So not that it's not important. There's a very large number of people that fall in that. I'm just not sure. I wonder if there's a way for our worker to sort of acknowledge that, but it would be somewhat silly for us to be over here creating our own thing when there's like 27 other work groups that are looking at housing and have, frankly, substantially more expertise in the area of housing in general and housing for this population.
Thank you.
I mean, I think the genesis of this particular process. Oh, I'm sorry. I didn't mean to interrupt.
No, go ahead, Alan. Go ahead.
I just think just to point out that the genesis of this process was that what came from your committee meeting a few meetings ago where somebody said these larger issues need to be addressed. And I think the question at the time was, do they get addressed in the recovery support services group in that recommendation, or are they beyond the scope of the group? And I think this acknowledges, maybe not everyone agrees with that, but this acknowledges that that number of those conversations are beyond the scope of the work that this group was charged to do. So, so that's a perspective anyway, and that's the hope is that this continues the conversations wherever. Yeah, and as Rep. Davis said, maybe those conversations are happening elsewhere, and so those need to get some other voices in them. But there it is.
All right, thank you all. Any more comments, questions, concerns? Amber, go ahead.
Yeah, I just wanted to flag really quickly on the timelines that are proposed. Just in my general experience with standing up a work group and putting a proposal together, you would probably need that work group to be starting about now to be able to write a proposal by July 1 of next year. So I just would encourage maybe a moving of the date. I think you could put it later in the fall and still be able to have it ready for the 2024 session if that's the goal, but you might give the work group a little bit more time to actually work on this and put a proposal forward.
All right, thank you. Last comments? Okay, Michelle.
All right. Real quick, just to follow up with Amber's comment there, that seems like an easy change that could that we could make right now, just to make sure that we're all on the same page about what's being voted on for the work group and the timeline. Is there any opposition to moving the date further into the fall for this? I don't want to pass what's written and just not address that easily if we can right now. Okay, Amber, what would the, yeah, go ahead.
I'm sorry. I think Amber's point is it would give some more flexibility to a work group if they were to make recommendations. So adding some extra time is what you're trying to clarify. I'm seeing, I listened to Rep. Davis, who, as I heard her, says this is essentially a duplication of other work going on. So I think maybe she's got her hand up now, or I saw her hand up now, but I just want to make sure that we can go ahead and vote, obviously, on this. And if people don't feel like it's a duplication, then we'd go forth as a recommendation for consideration. But Rep. Davis, I see your hands up. Do you want to maybe get a little more specific in your thoughts there before we do the vote?
Yeah, thanks, Michael. I was just going to say, I mean, I personally wouldn't vote for this because I think that's the thing that people hate more than anything about government is when the right hand doesn't talk to the left and we're funding using taxpayer dollars for two work groups doing the same thing. But I don't want that to reflect a sort of a lack of concern for housing for people who use drugs. That's an incredibly important. So I just wonder, I don't know if we're allowed to make amendments on the fly, probably not. Like Malika's correct. The answer is actually more housing. That would be a 2-word recommendation. Like we need more housing for people who use drugs. And that also is a continuum, right? Some permanent supportive housing, some other types of housing. Or we could, ditto the work going on elsewhere. I just think we don't have enough insight, frankly, or I don't, I'll speak for myself, into the enormous amount of work going on related to strategic planning for units and operating dollars for housing for people who use drugs that's happening well outside of this committee.
Go ahead.
I'm just thinking out loud here a little bit, but maybe we take the vote and see where people are. I don't hear anyway not committed to expanding housing capacity, and perhaps coming out of this committee could be a I guess, a voice to support those that are working on this, if I'm understanding that others are properly and trying to find ways of expanding it. Maybe it's just adding a sense of encouragement to do it as soon as possible. So anyway, I'll stop. I'm just thinking out loud of how we can make sure that the intent stays there without duplication.
I see Caleb commented, there's a few comments, but Caleb asked, do we want to do a ceremonial vote saying we support more money for supportive housing? Not sure it's meaningful. And then there were, let's see, Lisa had commented, for SURSAC not to address this seems very odd. That was the reason we suggested a work group could join with other processes. Sarah Melfi-Klein said, exactly, we definitely want to address housing for the population. This recommendation is aiming to include. If my vote doesn't go to moving this forward, that doesn't mean because I don't think it should be a priority. And then Rep. Davis shared a link to a current work group on the topic. Tim said, frustratingly, within the RSS subcommittee, the need to provide housing for people actively using drugs was voiced since its inception. It is a hard pill to swallow to see this recommendation making it in the 11th hour with the answer being a work group. Lisa, it would be very strange not to include this in the SURS plan. Rep. Davis, I would encourage members of this work group to participate in that work group created under HB 1724. Lisa says, well, recovery housing is detailed, but shouldn't this be in the plan? Caleb says, we need more supportive housing and many more supports in housing and a lot more workforce. It is recovery, treatment, and harm reduction all in one. Yeah, I'm not hearing a clear path of, how to move forward with this one. Malika, go ahead.
I was just going to say that it's frustrating because all the things that are being said in the chat were things that I attempted to say during the meetings, and other people did too. And it is, I just want to put a fine point on this is how stigma shows up in policy making. People have been asking repeatedly to have, with the recognition that recovery is not just abstinence. So, I'm not trying to scold people. I'm trying to put a fine point on this is how it shows up. Stigma shows up in the way that we create policy. So we need to do something different. I'm not going to say that I'm the only person that has that answer, but we could have been putting a lot of effort into this all along the whole process. But those that are going to financially benefit and that are already accepted as valid by the healthcare authority were the ones that got listened to, not people that were advocating for a broader path to recovery. So I think that, I don't know, it seems we've been making 11th hour recommendation, or not, excuse me, not 11th, we've been making random changes to recommendations throughout this process. I think we could potentially make some word changes around that. It's not just that work groups join together, as was suggested earlier in one of the recommendations, so there's not a duplication of work where people are not speaking to each other, and that there's a I don't know, that there be a real commitment towards funding housing along the continuum.
You want to, any objections to looking at that? Looking at the language, trying to amend? Okay. Michelle, did you want to
Yeah, let me see if I can try to cover that. So provide more funding for housing for people who use drugs. Let me know if I need to change this language at all. I know that sounds vague. I'm not sure what ensure looks like in action, but does that capture it? Sounds like what we want to ensure is that there's more funding for housing for folks that are actively using, and not creating a new work group, but ensuring non-duplication by encouraging communication between existing work groups on this issue, with that as one of the main objectives, the providing more funding for that group of people. Julian, go ahead.
Yeah, I would add, make sure that's rooted in the continuum of care.
See Caleb's comment there.
I don't think we need to call it behavioral health housing, not sure the best term. Housing that will welcome and retain people who use drugs. Right, yeah, I was not sure if we wanted to limit the recommendation to that group of people specifically, or just make sure they were included and emphasized in it, but I can certainly take that out. So I don't know if the other work groups are focused on that specific population. I want to housing, okay, focused on housing that will welcome and retain people who use drugs. All right, so provide more funding for housing for people who use drugs and ensure cooperation and collaboration among existing statewide work groups focused on housing that will welcome and retain people who use drugs rooted in the continuum of care. Any concerns or suggested edits to that, or is that what we want to be voting on?
I don't know if you saw Tim's language in the, sorry, I didn't raise my hand. In the chat.
I think it's important to not conflate drug use with those experiencing homelessness, but it is true in many settings that drug use is the barrier to receiving housing because housing providers who allow drug use are limited. Okay. Was that the comment, or was there a previous one I missed?
I think that was it. You have Sarah's hand up. Sarah's hand up as well. Sarah, go ahead.
Yeah, I'm just unclear if we're changing this language for the recommendation, but voting to move it forward. Is that with current language? I guess I'm just a little bit confused as to what the vote will be on, seeing that we've just changed like the summary of the recommendation.
Mm-hmm. Yeah, so a lot of the language in the recommendation was about the work group and who would be on it and what they would be discussing. So my understanding is that if we're not creating a separate work group, none of that language directly applies anymore, because what we're focusing on is a recommendation to provide funding for a specific kind of housing for a specific population, and ensuring that the existing work groups can collaborate on that objective. So it's my understanding that, yeah, that we're like focusing on the language that's on the screen now, and the existing recommendation language would no longer apply if we're not creating a separate work group.
Okay, but do we have time to change the language of the full recommendation itself? I guess I don't understand how we're voting on something that we don't know what it is yet. Maybe I'm the only one who's confused.
Yeah, I mean, this is an unusual situation. I just want to
We're
make
gonna go
sure that
back to
we're, yeah, so
back to
what's
the
that, Blake?
original language. We have about 10 minutes until we need to move on. Did we have time to go back to the other language, or Michael, you have another idea?
Yeah, I'm not sure the best idea. I mean, I think we could take the vote on the original language. If it's voted down, I think there's enough sentiment here to at least align ourselves with other work that's going on in this area. We put the language in, provide more funding. We haven't had time on the fly here to figure out what that would look like, right? So there'll be no funding attached to this. So it does get a little bit complex, but yeah, I guess to me is it, we've heard some voices say that there's concerns with existing language. You should probably figure out where people are with that, see if it would pass, and if it didn't pass, then do we want to put out a call to join other efforts and try to enhance the housing availability for folks who need it, who may be using drugs.
So you're proposing that we vote on the original?
I think so, and then
does not pass,
come back
to defer. Okay.
Yeah. And then see if we have a few minutes, can we go ahead and do something like the proposed language, some general statement about aligning efforts and trying to support additional efforts. I'm not sure we have time to do much more than that. But.
So go ahead and pull up the voting tally, and we'll go this. So I saved the option for the original language. So we'll vote on that one. So please refer to the document, the written recommendation for the details about what we're about to vote on now, the Continuum of Housing Work Group as it's written. If you support the Continuum of Housing Work Group to be included as part of the plan, please raise your hand now.
Michael, you want to take your hand down?
Yeah.
Thank you. I see 0.
Okay. All right, and if you do not want this to be included in the plan, you don't support this as a recommendation at all, please raise your hand now.
Caleb Bantu Green.
Okay. And if you are open to discussing this topic further, but would like to defer the topic, go ahead and raise your hand now.
All right, that's where we fall. Sarah Melfi Klein, Amber Daniel, Julian Saucier, Teresa Atkinson, Senator Dingra, Addie Adwell, Alexi Orr, Sarah Gillard, Malika Lamont, Sherry Candelario, Rep Davis, Donnell Tanksley, and Amber Leaders.
I think I saw 13 when most hands were up. Okay. You can lower your hands. Alexi, I'm lowering your hand. Okay. Chad, did you have a comment? Okay. And if you are abstaining,
I was just being early to the abstain.
Okay. All right. So if you are abstaining from this vote, please go ahead and raise your hand.
We have Chad Enright and Michael Langer.
All right. So looks like majority voted to defer on that one. Thank you, everybody, for your participation there.
Now, Michael, did you suggest that we go into that right now?
Well, I know we just have a few minutes. I feel like there's some sentiment among this group to support housing along the continuum for all. And I don't know if we just make that statement in the report and encourage folks or encourage inclusion in the existing committees that are happening. I think that's about as far as we could probably get today. Open to other thoughts on that, but I don't know if we take a quick vote on that and see if people would agree that we make some statement in the plan. But we won't have a chance to get back to details before the plan is written. So.
Okay. So I guess I'll Michelle, call out the vote for all four, adding that language to the plan about supportive housing for everyone. Rep. Davis, did you have a comment?
Yeah, I mean, I think it's pretty clear we need to do something a little bit stronger than that. Are we literally not allowed to just, in the legislature, we make oral amendments? Can't we just, I mean, say, have a standalone recommendation? It doesn't have to have several of these recs, I'm assuming, need some massaging and there's layers of approval, et cetera. Can't we just we obviously need an enormous investment in an array of housing options, a continuum of housing options for individuals with substance use disorder, people who use drugs, and plus the language that people did work hard on related to that recommendation, not necessarily creating a new work group. It feels inadequate. An enormous percentage of the individuals that we're talking about in the SURSAC committee are in active addiction and need housing. So I think we'd be remiss not to say something to that effect. And I don't think it needs to be extremely well defined because there's so much work related to permanent supportive housing and other housing modalities for individuals with behavioral health challenges who are not in recovery per SAMHSA recovery residence definition.
Thank you. So could we bring that language up? I mean, Michelle, do we have enough? I mean, just real quickly, we can get this done in the original, rather.
The document itself? Sure.
Yeah. So I've seen this remove. So I'm looking through the chat here. There was a suggestion a couple of times to remove one piece of language. Do you have that up, Michelle?
It's up now, yeah.
All right, thank you. Around the type of housing it was. Sorry, I'm not finding it right this second in the chat. Anybody have thoughts that want to chime in about that? Addie, I saw your hand up. Do you have something you want to add? Go ahead.
I just wanted to say out loud that I really agree with what Lisa Dugard wrote in the chat, that this is so impactful. And it's so crucial that we get this in the plan.
Okay. We heard that a couple times here. Thank you. So what language do we need to change in this to make it work? And we have probably about 5 minutes for this, 5 to 10, at least at this meeting.
Yeah, it sounded like just removing language around what the work group would work on and make it more direct. So rather than establish a funded statewide, work group to provide options, we would just say provide options. Like start with that kind of language. Is that right?
Yeah. That sounds.
That's what, at least that's what I was hearing. Okay, so provide options for housing at the various points of intersection along the continuum of care for people who are currently using, to those who are in recovery or seeking recovery. I think there was a comment about to clarify, abstinence as one of the on the continuum of recovery and not defining recovery itself, right? So
yeah, I think it's in the chat, Michelle, if that's helpful for you. It was back a little ways, but there was some language in the chat about how to say that.
Okay.
Around like 1137, Sarah Melfi Klein, publicly subsidized housing without abstinence as a term for occupancy.
There we go. Thank you.
You're welcome.
Sarah, is that what you're going to say?
Yeah, that, and just, I think when we're talking about this recommendation, it still speaks to a continuum, like up to and including abstinence. And we definitely want to include abstinence, but want to be clear that, you know, we've already put forth a pretty robust plan for recovery housing, I believe it's defined as in SAMHSA. So to make sure that we're putting forth an equally, I mean, I know it won't be able to be as robust in this time, but that we're focusing on other populations who wouldn't be included in that umbrella that the other recommendation was made for.
Thank you. Okay. We caught up, Michelle?
I don't know that. I don't think that I am. I'm wondering what to do with this piece, the funding part, if this work group isn't going to receive funding. I mean, funding is needed, right? Maybe just put it up here, provide funding for options. And then this piece about centering people with behavioral health conditions with the lived experience seems important as well. But we wanted something about collaborating with the existing initiatives and work groups, right? So I think that's where I need some help.
So if you look at the chat again, Michelle, Lisa's made some suggestions here. Starting, instead of provide funding, this committee urges that legislature provide funding for options, something along those lines, with Representative Davis specifying it should be capital budget and operating funding. Needs to be specified in there somewhere as well. I'm just watching the chat and there are a lot of really good suggestions coming through. So these are not my
okay,
ideas.
great. Thank you.
All right, thank you. Appreciate it.
All right, sorry, it's hard to be writing and tracking the chat as well. Is there anything else in this main bolded part that needs, I mean, this work should, I'm not sure what to do here because we're not talking about a specific work group anymore. The permanent housing. Is it enough to say collaboration is also strongly encouraged between existing work groups, and these should center people with behavioral health conditions? I'm not sure.
I think something along the lines of collaborating with what work is already being done. Like Representative Davis was saying earlier, like there is work being done, and I heard a lot of people saying, yes, we should be collaborating with that as opposed to coming up with our own process. By the legislature, which is, yeah. We recommend the work is centered on people with behavioral health conditions who have, I'm not sure what you're trying to say there, so I was just trying to make it sound right.
Yeah, the original work group was wanting to center people with behavioral health conditions, you know, to have them really drive the conversations and the work. So given that we're not creating a new work group here, I'm wondering how to incorporate those folks into the existing other work groups.
Sure.
Yeah.
My only issue is, even though the state recognizes behavioral health to cover mental health and SUD, when a lot of people read behavioral health, they only think mental health. That would be my only kind of point of clarification that we might want to. Sorry, I'm just helping. It's just like,
yeah.
No,
Stop raising my hand about 10 minutes ago.
How's that read? All right.
I like it.
Okay. So this, I think.
Michael has something in the chat.
Yeah, I think we can make the recommendation push to center voices of people, in existing work groups. So last sentence still. Okay, great.
Yeah, so that Michael Langer, I liked what he said about it is urgent that the legislature fund a continuum of housing and housing services for individuals who use drugs and those who are abstinent. The resources need to include capital and operating investments. Well, where were you 10 minutes ago, Michael? I know you've been here this whole time.
Okay.
Blake, my screen is black. I don't know if everybody else's is. So
No,
do you have language that we can put on?
I can still see it. I can still see it.
Okay.
We're including your thoughts, and then we have Sarah's thoughts. Malika can't see it either, so some of us can.
That's strange. Okay, I'll stop sharing and then share again. And just to be clear, Michael, we this is a statement to be included in the plan, but we don't have time to build out a full document as we've done with the rest, right? But we are wanting to make sure that this sentiment, this this is included in the plan the way. Yeah. Okay.
Yeah.
So that's
people
what
agree
we
to it.
can vote on next.
Yeah.
All right. You're trying to
Okay.
bring it back up?
Yes. All right, so this is the language that we'll move to vote on unless there are any additional pieces to add. I see, Lisa, your comment.
No.
We've just ditched a lot of subject matter expertise. There should be, I mean, within the other work groups working on this, I assume there's a lot of subject matter expertise there, but if you wanted to specify anything specifically in here, please, make those suggestions.
Well, the recommendation from the work group didn't pass, right? It was deferred.
Right, that was
And
deferred.
So given we can either stop there and move forward, or we can put some language to try to get the spirit of this into the plan, so that the sentiment is carried forward, if not the full proposal.
Right. The recommendation for funding. Well, Lisa, a lot of the language in the recommendation was about the work group, so that I don't know how we're going to keep it and remove the work group. That's the only problem I see with that.
Without a little more time here.
Without a bit more time. So just to recap, the SURSAC urges the state to provide capital budget and operating funding for options for housing at the various points of intersection along the continuum of care for housing people who are currently using, to those who are in recovery, which may or may not include abstinence, from immediate shelter to bridge transitional housing through long-term permanent housing. It is urgent that the legislature fund a continuum of housing and housing services for individuals who use drugs and those who are abstinent. The resources need to include capital and operating investments. Participation in and collaboration with work on these topics already being done is also encouraged. We recommend that the work is centered on people who use substances and/or experience mental health conditions, who have lived and living experience with homelessness and/or housing instability. Okay, so we've got about 4 minutes left. We all right to move into the voting?
And we can massage a little bit. We were talking about Sarah.
Yeah, I think to Lisa's point, there were examples of models that are already working that could be expanded upon in the initial recommendation that don't necessarily necessitate or call out that it's, you know, we're talking about a work group. It's just, you know, I'm looking at, right, some other examples like expanding on the HARPS program, expanding long-term rental resources. So I think, to her point, there's just a lot of good stuff in there already that we could theoretically include that don't reference the work group. So I just want to bring that to the forefront.
Yeah, yeah, and maybe it makes sense to note that as you know, so that's part of the participation in and collaboration with those other work groups. So bringing those ideas into those other work groups could be a way to make sure that those are seen and considered within the existing spaces. So I can add something like that here. So participation in and collaboration with work topics already being done is also encouraged to bring forth known models and systems that should be considered.
Okay, we're down to 2 minutes now. We better get to the vote.
All right.
I think it's important to name the models. The fact that you're choosing not to do that means that it's going to revert back to what you've already made a definitive decision, the measure that already went forward. So I just want to throw that out there.
Can we name the models?
Yeah,
it's literally a matter of cutting and pasting.
Yeah.
Yeah. Can we move to the vote, or I mean, I don't want to take time doing that when we've got only 2 minutes left, but I'm happy to cut and paste right from the document into that, and we'll include that in the statement if this passes in the vote. Okay. So please refer to the language that we had just looked at, including the list of the models that were meant to be considered in the original recommendation. Those will be added in to that language. So if you support that statement, that language going into the plan for the funding and the collaboration with other work groups, please raise your hand now.
All right. Teresa Atkinson, Sarah Melfi Klein, Alexi Orr, Caleb Banta Green, Julian Saucier, Rep Davis, Sarah Gillard, Hattie Adwell, Malik Lamont, Senator Dingra, Sherry Candelario, Amber Daniel.
All right, so counted 12 there. You can go ahead and lower your hands. All right, and if you do not support this going into the plan, please raise your hand now.
C0.
Okay. And if you would like to defer this conversation as well to discuss at a later time, please raise your hand.
See Donnell Tanksley.
All right. And anyone abstaining from the vote, please raise your hand.
Chad Enright, Michael Langer.
Okay. Great. So I'll be sure to provide the updated language to everyone so you have a copy of what that revised recommendation is. And thank you so much, everybody. We are at 12:01 now. I know that we had one final agenda item. Michael, how would you like to proceed?
Well, we've gotten the voting in, so thank you all. That's really, really important as we have to get the plan drafted and just a matter of a few days in order to get it through the internal process. So thank you for your contributions, your extra time, and all of that. We are planning to reconvene this group in December to talk about next steps and for 2023. So I think that's the closing out is just a whole lot of gratitude for the time and thinking and honesty that was brought forth in the process. Blake, thank you for your facilitation, and Michelle and all the staff for supporting the process. But at this point, we'll go in and hunker down and get the report written so that we meet our internal timelines. So thank you all.
Thanks, everybody.
We go done.
Really good job, guys. This has been hard. I appreciate what you've done.